Hi, good evening. Thank you so much for joining us tonight for our webinar. It is brought to you by Texas Fertility Center, and my name is Monique Hill. I'll be the producer of tonight's webinar. The guest speaker today is Dr. Erica Munch with TX Fertility, and the topic today is treatment for PCOS. We're really glad that you could join us tonight, and we really would encourage this to be participatory. We would love for you guys to ask questions that you have. Dr. Munch will stop halfway through, and then she'll answer more questions at the end. You'll see at the top right-hand corner, there's a place where you can ask your questions. Please know that your questions will be confidential, so please do not worry about any of your information being disseminated out or leaked out. So feel free to ask anything you're comfortable asking on here. And just know that what you ask is probably things that other people are wondering as well. So please don't worry about what kinds of questions or if it's a good question or not. We really encourage you to use this time to be able to interact with Dr. Munch. Before we get started, I did want to let you know that these webinars are brought to you on the third Thursday of every month. If you'd like more information on upcoming webinars, you can go to txfertility.com and you can go to the link at the very left-hand side, Getting Started, and it lists what the events are there. The next webinar, which will be in October, is Fertility 101. And you may think you know everything about Fertility 101 and the basics, but again, people ask all kinds of questions, so you may learn something new. And then we take a little break in November and December because it's the holidays and people get busy. And then we will start back up again in January with IVF orientation. So for now, I'd like to just go ahead and get started, and I'd like to introduce you to Dr. Erica Munch.
Thanks so much, Monique. Hi, everybody. My name is Erica Munch. I'm a reproductive endocrinologist here at Texas Fertility Center. I am actually based in the San Antonio office. You may also be familiar with some of my colleagues, both in the Austin offices, as well as New Braunfels and Corpus Christi. We're kind of all over the place, and I'm joining you here from San Antonio today to talk with you a little bit about polycystic ovary syndrome. So the way I'd like to do this, and just like Monique had mentioned before, this is quasi-interactive. I'm speaking to you all from the webinar system, but you're certainly welcome to chime in and ask some questions, which I'll address. So first, I'd like to start by talking a little bit about PCOS, what it is, what it's not, answer some questions, and then kind of use the second part of the webinar to talk about fertility treatments related to PCOS and just general things to talk with your gynecologist about if you're not planning for pregnancy right now, but thinking about pregnancy in the future and what we do. Like Monique said, if you have some questions, feel free to ask them during the webinar. I'll be addressing some of those questions and kind of talking about those things as those topics come up. So, what is PCOS, right? It's kind of a diagnosis that a lot of people are scared about or they've heard about. A lot of people have friends or family members that have PCOS. So it's relatively common, right? So it's not a disease, right? Polycystic ovary syndrome, which is what PCOS stands for, is a constellation of symptoms that go together to help kind of explain some of the physiology that some women have with regard to irregular cycles. So when people have PCOS, women that have PCOS typically are in their kind of teens, 20s, or 30s. They're of reproductive ages. And usually it's characterized by having infrequent periods. Not always, but most of the time, most people will have less than 8 periods in a year. Okay, so they'll go every 6, 8 weeks, sometimes 3 or 4 months. Some people don't get periods at all unless their doctor prescribes them something to kind of trick their body into having a period. So definitely having irregular cycles is one of the hallmark features of PCOS, but it's not the only one, right? There's other things that can cause people to have irregular cycles, and that's why seeing somebody like me, a reproductive endocrinologist, can help figure out what's just an irregular period because of PCOS and what's an irregular period because of something else. The second symptom that some people have with PCOS is evidence of male-type hormones that we all have, called androgens, but having a much more potent effect in women that have PCOS, meaning that, yes, all women have testosterone, even just small amounts of it, but some women, their testosterone has more of an effect in them, and sometimes they have elevated levels of what we call free testosterone or some other types of androgens. And so for them, women will have increased evidence of that testosterone effect in their bodies. So thinking about hair growth, kind of that pesky stuff on your chin, on your lip, sideburns, hair about your belly button, a little happy trail. So all those things are characteristic for women that have elevated androgen levels, or what we call hirsutism. Not all women that have PCOS have that, right? But that's another one of those things. It's like a tick in the column to say, you know, could this be PCOS? The third characteristic that some women, not all women, have is evidence of polycystic ovaries on ultrasound, okay? Some people have had ultrasounds before, some people haven't, but may have had those other two symptoms, right? So polycystic ovaries on ultrasound is more than just having cysts on an ultrasound. Almost all women have cysts at some point on their ovaries, even during a normal menstrual cycle, or you know, cysts that are functioning to try to make an egg for that month, right? So cysts in and of themselves are not a problem, but in PCOS, when we see these tiny little cysts scattered throughout the ovary, they're kind of evidence of the problem, right? The problem being that a lot of those little cysts are trying to ovulate, they're trying to get the right signal to be able to grow and develop, but for whatever reason, they don't get there, and so they kind of hang out, okay? They die off, other ones show up, but when we see lots of those little ones without any big ones, that's what we call polycystic appearance, okay? So the diagnosis of polycystic ovary syndrome, as one of my colleagues likes to say, is a diagnosis of exclusion, right? It's my job to figure out if there's other reasons you might have those symptoms besides something called PCOS, because that's a pretty broad diagnosis. So typically, women that have PCOS or polycystic ovary syndrome will have at least 2 out of those 3 symptoms that I mentioned. Some people have all 3. If you don't have 2 or 3 of those, there might be another reason that you have, you know, these irregular cycles or evidence of hirsutism that we need to investigate. So when we're evaluating somebody that has irregular cycles or somebody that might have PCOS, we do some testing, right? We'll do an ultrasound. We'll do usually some blood work, do a physical exam, right? Check for those things that I mentioned. So there are other things that can masquerade as PCOS that can cause irregular cycles. Sometimes women will have thyroid issues that can cause irregular cycles. Some people, sorry, I should turn that off. Some people will have irregular cycles as part of thyroid issues. Some people will have kind of some enzyme deficiencies that can sometimes cause irregular cycles. Sometimes people can have elevated hormones that cause other problems beyond just irregular cycles, and it's our job to do a thorough investigation. Very rarely, some people can actually have problems with kind of general medical issues, and maybe they're sick for other reasons, and that's manifested as a stress to the body, and that's what causes them to have the irregular cycles. So there's a lot of different things that we can that sometimes happen with hormones that can cause irregular cycles, and PCOS, like I said, is a diagnosis of exclusion. So one question it looks like I've received, it says, I hear that PCOS can improve as I near menopause. And so kind of how does that happen, right? Do you grow out of having PCOS? And the answer is yes and no, right? Some women, especially early on in their reproductive years, in their teens, will get irregular cycles just because the body is not very mature. When I say the body, you know, your breast might be mature, you might be menstruating, but from a brain and ovary connection, it hasn't really been fine-tuned yet. And so some people will have irregular cycles just as that hypothalamic pituitary gonadotropic axis is maturing. So that can be the reason for irregular cycles. Oftentimes, people who have a really high bank account in the ovary, good ovarian reserve, will have PCOS. And as that reserve declines, it becomes a little bit easier for the brain to recruit eggs each month. And in that case, it ends up being that people will notice a little bit more regularity of their cycles. And then finally, one of the things that can sometimes masquerade as PCOS is actually just carrying extra weight. So having extra adipose tissue, or women that are overweight, obese, or morbidly obese, their adipose tissue actually makes hormones, believe it or not. And those hormones can interfere with your brain and your ovary talking to each other. So some women that are overweight or obese don't actually have PCOS, but they will have irregular cycles and they will have that evidence of hair growth. And it's not because of PCOS, it's actually just because of the extra weight. And they will notice that in times where they've carried that extra weight, that their periods are more irregular, okay? And sometimes they'll have had bariatric surgery, they'll go through a period of a lot of weight loss, and they'll say, hey, I lost this weight, and now my periods are back to normal. And that actually is, one more thing, tick in the column to say maybe that wasn't PCOS, maybe that was actually just the extra weight. So that's something that we evaluate. Let me look at some other questions here and take a look. One person asked, could PCOS go away after I get pregnant, right? So again, that's kind of one of those things where, did it go away because of the pregnancy? No. But over time, women will sometimes have had pregnancies, and then later on in their reproductive years, they're finished having kids, but they'll notice like, hey, my period's actually coming regular now. And it's not the pregnancy that made that regular. It's just the fact that time has passed on, and maybe some of those hormone regulations have worked themselves out. All right. So hopefully it is clear now as far as what PCOS is and what it's not, and how we diagnose it. One question is, my primary doctor diagnosed me with PCOS, and kind of when is the right time to see a specialist, right? So it really kind of depends on what we are diagnosing, who is diagnosing the PCOS, and what part of it is affecting your world, right? So in two categories, which we'll talk about here in a little bit, there are women that have PCOS that are trying to get pregnant, and there are women that have PCOS and are not trying to get pregnant. And when somebody's trying to get pregnant, they usually see somebody like me because we're actively working towards getting you to ovulate. For women that might be diagnosed with PCOS but really aren't kind of concerned about their fertility at this very minute, it might be very appropriate for their primary care doctor to manage their PCOS, specifically if it has anything to do with the hirsutism that they're able to take care of from like topical treatments. Some people will have associated insulin resistance with PCOS, which I'll talk about, and they might be having their insulin resistance or weight management managed by their primary care doctor. If their primary care doctor does not feel comfortable managing PCOS, of course, then it's time to go see a specialist, either somebody like myself, a reproductive endocrinologist, if you're trying to get pregnant. Generally, a medical endocrinologist is somebody that you would see if you're not currently trying to get pregnant, and they would be able to help manage the symptoms as related to PCOS. Okay. One thing that is, we get questions about this sometimes too, about PCOS. Some people say, well, I have PCOS, so my doctor put me on metformin. Okay, what's metformin and why would we put somebody on that? So some women that have PCOS have some degree of insulin resistance. And that's why oftentimes when you're getting worked up for PCOS, we'll check your blood sugars and kind of see how they've been running. Back in the day, you used to make you drink an oral glucose tolerance test and make you sit around for 2 hours and check your blood sugars to see if you were diabetic. Kind of like the pregnancy test, the one that the ladies do, right, when they're about 3 months away from their delivery date. They will have a glucose challenge test. And so when we would evaluate people for insulin resistance, they used to do that test. Nowadays, most people will get fasting blood sugars or something called a hemoglobin A1C to look to see if they have insulin resistance. Now, there is some thought that women that have PCOS to some degree have some insulin resistance that might be very localized actually inside the ovary. So believe it or not, we have insulin receptors even in our ovary that help with some of the signaling that happens between the cells that are helping those eggs mature. And some women that have insulin resistance, those signals don't work quite right. And so that's why, again, the cycle doesn't fire, the eggs are not getting released in a reliable manner. And some women will have insulin resistance in other places in their body besides their ovaries. Again, extra weight gain, right? So some women that have PCOS are more prone to developing extra weight. You can't get away with eating the same things that a lot of your friends can, probably, and you've noticed that. Some people will have full-blown diabetes. Some people will have something called metabolic syndrome, which is not just fat, problems with blood sugar, but also associated high blood pressure, increased cholesterol, extra fat around the abdomen, or what we call central adiposity. So all of those things can sometimes go hand in hand with PCOS. And we know that women that have PCOS, that it's important for them to be monitored for those things because they're at more risk of developing those things. So let's talk about, I think I talked a little bit, somebody asked about metformin, whether or not you should be or not be on that medication. Metformin, again, it's a good medicine to use if you have insulin resistance, right? In and of itself is not going to make the PCOS go away. We used to put a lot of people on metformin that had PCOS. Probably more recently, there's many other drugs that we can use to help people with pregnancy beyond just metformin, and we'll talk about some of those as far as the next steps. What I'd like to do now is kind of talk a little bit about how we manage PCOS for women not trying to get pregnant, because the bulk of my time is going to be spent talking about how we manage PCOS in leading up to pregnancy. So as far as, like I said, with PCOS, we do know that those women tend to have what we call comorbidities or other existing conditions that might be kind of stressful on them, not only thinking about health now, but health in the future. So women that have PCOS are more likely to develop diabetes, high blood pressure, increased cholesterol, and sometimes an overgrowth of the uterine lining on the inside. Okay, so how do we address that? How do we address that for people that are not trying to get pregnant? Well, of course, if you have PCOS, like make sure you have a general practitioner or family medicine doctor that takes care of you and make sure that your blood sugars are staying good, especially if you have family history of diabetes. That's super important. Making sure that your weight is under good control, helping you with weight loss, or sending you to a dietitian or bariatric surgery, or people that give prescriptions for medical weight loss stuff. All those things are really important. Thinking about managing your blood pressure, making sure your blood pressure is good, because we know that women that get pregnant that have PCOS are a little bit higher risk of gestational diabetes, which is diabetes within a pregnancy, as well as preeclampsia, which is elevated blood pressure issues that can manifest as placental problems with a pregnancy. So making sure that those things are all in good control, even if you're not trying to get pregnant yet, because that's one step in the right direction when it does come time for you seeking fertility. All right, take off my reproductive hat and just put on my good old gynecologist hat here and talk about that uterine overgrowth problem, right? So you may not be trying to get pregnant right now. Maybe you could care less if you're not getting periods very regularly, okay? But as a gynecologist, I care about your uterine health and making sure that we don't have an overgrowth of the tissue on the inside of the uterus. So you might only get periods once or twice a year, right? And that sounds amazing, right? But it's not actually amazing for the inside of your uterus if you have this overgrowth. When you have lots of estrogen, it's just kind of building things up. You may notice when you do get that 1 or 2 periods per year, it's crazy bad and it's heavy, and you might be soaking through pads or tampons. So when we have women that have really irregular cycles, even if they're not trying to get pregnant, it's best to either make sure you're getting at least 3 or 4 periods a year, okay? Or to be on something that helps prevent that overgrowth. For most people, if they're not trying to get pregnant, being on some kind of birth control is actually the best thing that you can do to not only prevent that overgrowth, but manage a lot of the other symptoms of PCOS. So being on something that has progesterone in it will help stabilize that lining on the inside of the uterus, okay, so that it doesn't overgrow. And for people who are not planning pregnancy, being on a birth control pill is usually a really good idea, because being on a birth control pill will actually reduce some of that hair growth and excess testosterone levels that might be in your bloodstream, give you pretty reliable periods, and give you a pretty good method of birth control to prevent unintended pregnancies. Okay, so those are a lot of good things in the right direction. Not in my world, because as a fertility specialist, most people don't want to be on birth control, but when you're not planning for pregnancy, birth control, IUD, patches, whatever the case may be, talk with your gynecologist about that and see what method is right for you, okay? Now let's talk a little bit about how we treat women that are trying to get pregnant with PCOS, which is probably gonna be the bulk of what we spend our remainder of our time on. So for women that are trying to get pregnant with PCOS, it can be really hard, right? Because I can give medicines that make you look like you're getting a period. We can put you on birth control pills, which of course will keep your cycles very regular. But neither one of those is going to get you pregnant. And so my job as a reproductive endocrinologist is to try to convince the brain and the ovary to talk a little bit better to each other. Like I said, back in the day, they used to put people on metformin, and that helps some people get more regular cycles if they have that insulin resistance problem in the ovary. But many women with PCOS still don't ovulate when they're on the metformin, and we have much other better medicines that are usually pretty well tolerated to help to get you to ovulate. For the past many decades, that medicine that we would reach for is a medicine called Clomid or Clomiphene. It's been around for 50, 60 plus years. It's almost always written as a generic prescription nowadays. And it's a medicine that directly tells your brain, convinces your brain it's time to send more signal to the ovaries so that it pushes some of those follicles along and helps get them to get to a point where they become mature. Okay. As a reproductive endocrinologist, when we use those medicines, typically we'll monitor those medicines by ultrasound. So you'll be on the medicines for 5 days, 8 days, and then we'll have you come back about a week later for an ultrasound to make sure your body responded to that medicine, right? Sometimes, and I love my GYN friends and they love what they do too, but oftentimes their offices are not really set up to be able to do that really precise monitoring at a moment's notice because they've got a lot of other patients to see and people to do, and that's fantastic, but sometimes not really set up to do that day-to-day stuff that we need to do from a reproductive endocrinology standpoint. So when we use those medicines, we'll typically have somebody come back in a week later, make sure that their body responded to that medicine and see that there is at least a follicle or two, like an egg that's developing, that's ready to be released, and use a different medicine, which sometimes you'll hear about called Ovidrel or HCG, like Pregnol and Overall. There's lots of brands out there to help make that egg come out by a certain time. So that way, you know what time to get busy and to make sure that you're covering your bases, so to speak. So that's what has been used historically to help people with pregnancy. Nowadays, we don't use Clomid as much as a first-line agent for women who have PCOS. It's still a good medicine. But there's another medicine called letrozole that has been studied specifically for women that have PCOS that may have a slightly higher chance of a live birth when we use that medicine first. So many people will use that medicine before trying Clomid and save Clomid for the people for whom the other medicine, letrozole, is not working. Similarly, through ultrasound monitoring, making sure their bodies are responding to those medicines, making sure that we have that egg come out at the right time. Okay. One question about kind of natural cycles, and how to know when you're ovulating. Okay. And that's a super good question. It can be kind of a frustrating question for a lot of people to answer. So what happens in women who get that 28-day cycle that we all are jealous about, their hormones do this all month, right? So sometimes the hormones are high and sometimes their hormones are low. And when they use things like basal body temperature, for instance, long story short, your basal body temperature in the first half of your cycle when you're building an egg is pretty low. And when your body gets ready to release the egg, and once it releases the egg, your temperature goes up a little bit. And when I say basal body temperature, I mean the temperature that you have when you're laying in your bed after a good 8-hour night's sleep and you haven't gotten up to the bathroom to go pee in the night, and kind of textbook perfect temperature. Okay. That's really hard to do. You're welcome to try to do it. But when we see that temperature elevate, ovulation has already happened. Now, first of all, most people don't get a good 8-hour night's sleep without going up to the bathroom or having to get up for other kids or any of those things. So sometimes it's hard to track a normal basal body temperature. And then what happens with women that have PCOS is that because ovulation is so unpredictable, sometimes they're going not just days, but weeks of trying to find out when that temperature finally increases. And again, it's retrospective. By the time we see it increase, you already ovulated. And other things can cause, temperature increases too. You can have, poor night's sleep, you can get COVID, you can have, strep throat. There's a lot of other reasons that you might have a 0.5% or a 0.5 temperature degree change for other reasons. And so women that have PCOS often find it really frustrating to track their basal body temperature chart because it's all over the place and it's never what we call a biphasic chart, which is what you'll see, on the internet. The other thing that sometimes women with PCOS will use is an ovulation predicting kit. Okay, those are the ones you buy at the store. They look like a pregnancy test. You pee on a stick first thing in the morning. And if you're ovulating, you're either supposed to get 2 really dark lines, or sometimes you buy the one that has the happy face and it might be blinking at you for a certain number of days. And then ultimately what we're all looking for is that solid happy face. Okay, now women that have PCOS, remember I said women that get a 28-day cycle have low hormones and high hormones, and it's supposed to change. Women that have PCOS just have like the brain and the ovary talking to each other, and it's like this. They're just not talking to each other, and they're not seeing those hormone changes that are needed to kind of jumpstart the ovary to doing what they do. So some women that have PCOS will check their OPKs, and they will never, ever, ever get a positive, and super frustrating and kind of expensive if you're buying lots of those tests. And some women who have PCOS will see like a positive every day, which is about as unhelpful as having a negative every day, right? Because what you're looking for is the change. So you're welcome to try ovulation kits, and you're welcome to try basal body temperature kits. But I find for most patients, it's really an exercise in frustration. And honestly, it kind of makes you frustrated and sad, right? Because it's just one more reminder every morning that you're not where you want to be. And really the best way to monitor for ovulation for somebody is by doing ultrasound to actually see what's going on in the inside. And then as a confirmation test for somebody who has already ovulated, you can check a progesterone level. Some doctors will do that after so many days of having used the Clomid, or if they're not monitoring by ultrasound, they'll say, oh, you should get a progesterone level checked. And that progesterone level will tell us whether or not somebody has ovulated or not ovulated, but it won't tell us when you ovulated. It's just more of like a yes or no answer. All right. Let's see. What else? Sorry, it's like, some people, I've had this, I actually had a patient ask me this a couple of days ago. She had asked me, she said, oh, my doctor, knew I had PCOS, so they put me on birth control pills to try to jumpstart things. And so some people say, can I take, one question I'm getting is, can I take a birth control pill for a short amount of time to help get my cycle and then get pregnant, right? And so again, the birth control pill just kind of basically keeps things at an even keel. I won't doubt that for some women, once they come off the birth control pill, it's kind of like popping the clutch, and their brain will be like, oh, it's time to do something. And that very first month, they might get a regular cycle. But then your body kind of goes back to doing what it was going to do. And so you'll end up getting the irregular cycles again without the ovulation. So again, for some people, being on the birth control pill and then stopping and seeing if that helps them spur ovulation might work. A better way to go about it would actually just to be on medicines that help you ovulate. And so because, being on 1 or 3 months worth of birth control isn't really something that most people who want to get pregnant are ready to do, because they just kind of see that as kicking the can down the road a little bit. And another 3 months of not getting pregnant before that 1 month chance of maybe getting pregnant. So let's see, what else? Can you build up resistance to metformin? That is probably a better question for a medical endocrinologist. Usually there's not much benefit to being more than about 2,000 milligrams of metformin a day when it comes to effective treatments for reducing blood sugar. Metformin is also a pretty not poorly tolerated medicine, but you can have a lot of GI upset and stuff. And so usually we don't put people on, 3,000 milligrams of metformin a day. You usually have to start with like 1 tablet a day first and build your way up. Otherwise you really will get those GI side effects. One person asked, they said that they had Hashimoto's disease and PCOS, and will it become harder to get pregnant just because of the Hashimoto's? As long as you're well treated for the Hashimoto's, we take that treatment of the thyroid into consideration, and people with well-treated Hashimoto's disease absolutely can get pregnant. And so I would say that, yes, that is a factor like anything else as far as, playing into the irregular cycles. But as long as it's well treated, we kind of take that off the table as far as a compelling reason why you're not getting pregnant, and kind of again focus more on let's get you to ovulate instead of let's look at all the things that are standing in our way. Weight loss and PCOS, a couple of questions about that, thinking about kind of what are the non-pharmacologic interventions you can do to treat PCOS, right? Again, there's probably very little that you're doing to cause PCOS, right? It's a medical diagnosis, just like other things. People get cancer, people get diabetes, and it's not because they wished that upon themselves, and it's not because they can wish it away. And the same thing with PCOS. It's a medical condition. And so, yes, for some women that have extra weight gain, losing the weight may help them get more regular cycles, but there are definitely people that are of normal weight that have PCOS, and some women have PCOS and they lose weight and they still get irregular cycles, and we still have to help them ovulate. So being in the best shape you can certainly is important, and it's important for lots of things, not just getting pregnant, but remember all the 9 months and the 18 years ahead of that you have to be healthy for that kiddo, and reducing the risk of diabetes, preeclampsia, the things that can affect the baby actually. And lead to a good birth outcome for the baby. So there's a lot of good reasons to try to lose weight prior to getting pregnant with PCOS. But with that being said, it's not the exclusive thing that we use to treat PCOS with. Insulin sensitizing drugs, are they dangerous if you want to get pregnant? That is a good question, again, for the doctor that's giving you those medications. So generally speaking, for women trying to get pregnant, metformin is almost always the safest bet besides insulin, as far as getting blood sugars under good control. Many people do use metformin in the first trimester of pregnancy. Insulin is the preferred agent for treating diabetes when you are pregnant. So if you're pregnant and you're having a really difficult time getting your blood sugars under good control with just metformin alone, or your doctor's got you on a lot of other fancy medicines that I probably didn't even learn about in medical school, some of them you're actually supposed to be off of for a month or two prior to getting pregnant. So if you're at all thinking about getting pregnant and you're on something that's not metformin or insulin, I would talk with your doctor to see if there's something that you can switch to. So that way, when you're pregnant, you don't have to worry about, changing everything with your treatment. All right. Is PCOS one of the leading causes of infertility? Is it common? Is it uncommon? It's fairly common, right? I would say that, ovulatory fertility issues represent probably at least 30 to 40% of the fertility that we see in patients, and probably half of those reasons are related to PCOS, right? There are other reasons that people get irregular cycles, right? We think about people that are closing in on menopause, right? Those people will oftentimes get irregular cycles in the years leading up to menopause. I've had some patients, unfortunately, be told that they had PCOS and that they're young and they'll have plenty of time to get pregnant. And then when they come to see me, because they're still not pregnant, they say, oh, I have PCOS. And then I look at their ovaries, I'm like, like you have very few follicles. And we look at your blood hormones and we say, no, you don't have excessive amounts of eggs. You actually have very few eggs remaining. And that's kind of a hard thing to know, because now our clock for getting pregnant has really started ticking really loudly. And then we have to do very different things to help them with pregnancy. So, other alternative treatments for PCOS. So again, making sure that your weight is under good control, making sure that if you do have insulin resistance issues, which is a very easy thing for us to check, or your general practitioner to check, making sure that is under good control. There is some data to suggest some types of supplements may be important for women that have PCOS. Again, myo-inositol is one that you'll see talked about. There's kind of some mixed studies on whether myo-inositol is helpful for women that have PCOS as far as fertility treatments. It certainly doesn't hurt anything for most people, so it's generally a pretty okay supplement to take. So just ask your physician about that. Sometimes people will say, well, what about vitamin D, right? So we know women that have PCOS oftentimes also have a low vitamin D. Making sure that the vitamin D level is in good shape does seem to be associated with better fertility outcomes for women that have PCOS, not other infertility patients. We don't know about those yet. We probably all need a little bit more vitamin D in our life. So again, it's probably not a bad idea to make sure that that you're doing what you can. And generally in a prenatal or a women's multivitamin, you're going to get enough vitamin D. So just make sure that you do that. Are there certain weight loss techniques recommended for PCOS? It's a really good question. So generally what I would counsel my PCOS patients for is, because they have insulin resistance oftentimes, and because, again, you've noticed that you cannot get away with eating the same things that most of your friends do, that you should stay away from the refined carbohydrates. So what I personally tell my own patients is to avoid the middle of the supermarket. Okay, so stay on the perimeter. Fresh fruits and veggies, dairy, meat, the bread that they bake at HEB that doesn't, sit on the shelf for 6 months and doesn't grow mold, right? That stuff we probably all should be a little bit suspicious about. Staying away from the delicious things that come in boxes and bags, right? So Oreo cookies, crackers, chips, bread that does sit on the shelf for 6 months and doesn't grow mold, right? All of those things have refined carbohydrates, and it's really difficult for women that have PCOS to be able to metabolize those things and not just send all that sugar directly to the liver so that it can be stored as fat. So staying away from the refined carbohydrates, linking carbohydrates with protein when you are eating carbohydrates. So don't just sit there and eat a box of crackers, which is delicious, but not, great for our health. Crackers and cheese, right? You probably won't eat as many crackers. You'll pair that with the protein. It'll help slow the absorption of those sugars, and you probably won't put on as much, extra calories as fat in that case, and it will help with that insulin resistance. So some people, will recommend certain diets. The diets that avoid the refined carbohydrates are like South Beach diet, which I don't even know if it's still a thing, or other diets. You don't need to go keto. Okay, keto is great for weight loss, but very, very, very difficult to maintain, and it's not so good for your kidneys. So we don't tend to tell people to do a keto diet for a permanent way of losing and maintaining weight, because that's just not sustainable. I mean, we all have to get through life eating normal things. So might be good for the short-term weight loss, but not good for long-term. So just kind of generally changing your dietary intake to be one that really emphasizes those things I mentioned on the perimeter of the supermarket: fresh fruits and vegetables, dairy, meat, carbohydrates that are smart for us to take. Thinking about IVF, that's another big question, and I'll probably kind of close it with other things that we treat PCOS with. So sometimes we don't find success using those medicines that I talked about. Some women will have really resistant ovaries, right? And no matter what we're doing to try to get their ovaries to respond, they're just not having it, right? And it becomes really difficult to get them to ovulate, right? So the other medicines that we have when we think about fertility treatments oftentimes are directly telling the ovaries to get those eggs to grow. All right. And those are medicines called Gonal F or Follistim or Menopure. They're injection medicines, and they are great medicines. Okay. Except, caveats, asterisks, when women have PCOS, when we give medicines like that, we have to be very delicate with the amount of medicines we use, because that's kind of, those medicines are kind of like playing with fire, especially for somebody that has PCOS. They have fantastic ovarian reserve, and it doesn't take but a sniff of that medicine to really kind of cause those ovaries to light up like a Christmas tree. And sometimes when you use too much of those medicines, you actually get an over response in eggs. Okay. And we don't want you to have a litter of babies all at once. That's not safe for you. It's definitely not safe for the babies. And so sometimes trying to use those medicines can put you in a difficult and unsafe position where we need to cancel our fertility treatment cycle, or you could be at high risk of developing not only ovarian hyperstimulation, but also high risk of twin, triplet, quadruplet pregnancy. So generally speaking, if we cannot get somebody to respond with those oral medications, the safest and honestly the most cost-effective and best way of moving forward, if you can't respond to those oral medications, is actually to think about IVF, which sounds a little bit, extreme, right? IVF is when we stimulate the ovaries to get more of those eggs to make it to the finish line. So we don't use up your eggs any faster. We're not going to deplete your ovarian reserve further. We're actually being much more efficient with the eggs that your ovaries is willing to make. But instead of getting 0 of them to make it to the finish line, which is what's currently happening, or getting 1 or 2 to make it to the finish line, which is what we do with Clomid or Letrozole, what we're trying to do is get many of them to make it to the finish line, but then we're going to take those eggs out of that individual through a vaginal ultrasound procedure and allow them to meet up with sperm outside the body, and eventually take one of those embryos and place it back into the uterus with a probably 50+% chance of pregnancy, sometimes higher than that, depending on what we know about that embryo. So that is a good way of getting pregnant if you're not successful with those simpler methods that I talked about, because the multiples risk is very low. the chance of success is very high. And if you have more than one suitable embryo available, that means we can use other embryos in the future for pregnancies down the road. So without having to do that big IVF stimulation again, now here we are 2 or 3 years from now, ready for baby number 2 and able to do another embryo transfer with the same high chance of pregnancy. So lots of things to think about with PCOS. Remember kind of 3 criteria: polycystic ovaries on ultrasound, increased evidence of hirsutism or male type hormones, and irregular cycles having 2 out of those 3 criteria. Thinking about the treatment for the diagnosis of PCOS being one of exclusion, okay, making sure that there are other factors that have been ruled out, like hormone problems, extra weight gain, other things that can cause irregular cycles. And then thinking about treating PCOS depending on whether or not you're trying for pregnancy or not trying for pregnancy. Okay, people who are not trying for pregnancy, we want to make sure that they're minimizing those other risks as far as diabetes, high cholesterol, high blood pressure, increased like metabolic syndrome risk. Okay, making sure that overgrowth of the lining isn't happening inside the uterus by being on a birth control pill or some kind of progesterone that helps minimize that and hopefully protects you against pregnancy. And then for people who are trying for pregnancy, again, seeing somebody like myself, a reproductive endocrinologist, who can help really fine tune the treatments that we're going to use to help those ovaries make eggs in a predictable way, all right, and in a safe and effective way. So either through oral medications or possibly doing something even as much as IVF, where we're identifying the best embryo up front pretty quickly. So with that, I will close. Thank you so much for your questions. I hope I've had a chance to address most all of them. And I'm going to turn it back over to Monique so she can finish up with tonight.
Thank you so much, Dr. Munch. Those were amazing questions. I think this is one of the most active question asking sessions we had, and I loved it. So thank you so much for your time. We know that you always have a long day in the office, and so spending this time with us at the end of the day is really appreciated. And I just want to encourage all of you again, if you have questions, to go to txfertility.com. There is a section in there on PCOS, and you can also find out about all of the Texas Fertility Center offices in the Texas area. And we thank you for all of your time. I'm sorry if we weren't able to get to all of your questions. You all had so many, and they were amazing. But thank you again for joining us, and we hope you have a great night.